Well, good evening, everyone, and welcome to the 179th episode of Question Lab. I'm Jeff Downing, and I am really happy that all of you have joined us tonight, and appreciate all your patience as we had to update our GoToWebinar system. So might look a little bit differently, but everything should work as usual. Tonight we're going to be going into step 2, specifically cardio, and our goal here is to help try to challenge some of your clinical reasoning skills and help you master some high yield cardiovascular concepts. So with me again is our old friend, Dr. Abraham Titus. Abraham, would you like to introduce yourself to the crowd?
Thank you, Jeff. I hope everybody can hear me. I'm still learning the system as well. So my name is Abraham Titus. I'm a third-year Hematology Oncology Fellow at the University of South Alabama. Been a coach with RX for quite a bit now, and I'm excited to be here today and talk about some high-yield Step 2 cardiology. Hope you guys learned something from today, and I'm excited to get started.
Very good. Thank you. And again, we've got a great crowd here tonight. So what we want to do is learn a little bit about you. So what we're going to do is we're going to launch our first poll of the night. And as usual, this is the easiest question that you're going to see. And it is, who are you? Want to know, got any M1s out there? Any M2s? Wouldn't be surprised to see a bunch of M3s here tonight, or M4s, or IMGs. So let us know. This is the apparatus that we use when we're asking questions. This is what you're going to use to answer questions. So once you've mastered this, you should be in good shape for this evening. Typically we wait until about 2/3, 3/4 of you have voted, and let's see, looks like about a little over 60% of you voted. I'll give you a few more seconds. This is always helpful. It's good for us to see who's out here and who's deciding to up their step 2 game. Okay, let's go ahead, and I'm going to end the poll and share the results. And okay, so we've got about 2/3 of you out here are IMGs, FMGs. We've got some M3s and M4s. We also have some M2s. So this is great. We've got a nice little mix, and I think we're ready to roll. So appreciate everybody's participation. If you are new to Question Lab, welcome. We've been doing this now for close to 5.5 years, actually. And, we use a very similar format. It's an interactive format. We're going to work through 4 hopefully challenging cardio cases together. And each question gives us an opportunity not only to get into the content, get into some of the concepts and the critical thinking, but also gives us a chance to kind of go over our methodology, because we do have specific techniques that we recommend that students use, especially if you don't have a technique. Now, some of you may have already taken step 1. Maybe you already kind of have a good understanding of, hey, once I get to this level, I kind of know what I'm doing. But some of you may be, I know we got a lot of IMGs here. Some IMGs like to take step 2 first. So we're just going to, kind of walk through the way that we answer our questions. And hopefully, there's stuff that you can pick up, maybe that will help you along the way. But either way, we're hopeful that that you're going to learn a lot here over the next hour. I do want to say that we are going to have a raffle at the end of tonight's event. One lucky attendee is going to get a free subscription to RX 360 Plus, which includes all of our questions, all step 1 and step 2 questions. Plus, we have a brand new self-assessment exam for step 2 that we just launched a couple of weeks ago. So if you have access to QMax or RX 360 Plus, you'll have access to this new SAE. So regardless, you need to be here to win. We'll also have a special offer for those that stick around. Okay, so with that, we're going to go ahead and get started. I think the first thing you're going to notice when we reveal the question is that something's missing. And those are the answer choices. We ask you, first off, go ahead and cover up the answer choices. We do this because we really want you to focus, and especially for step 2 questions where you've got, in some cases you've got long vignettes. You may have, different, could be EKG readings, you could be having all kinds of labs. It's very important that you're really getting through that item methodically. So what we want you to do is cover up those answer choices, because sometimes you might see a distractor or something's going to catch your eye, and it's just going to snag you. It's going to snag your thinking. Sometimes it's maybe it's a drug you haven't seen before, or you're very unfamiliar with, or maybe there's a concept there that has tripped you up in the past. We don't really want you to lose your train of thought as you're going through this. So the first thing we say, cover those answer choices. Second, read the lead in. And the lead in is the actual question. So for question number 1, the lead in is, which of the following most justifies the initiation of statin therapy for this patient? Now, for those of you who have always read the vignette first, or might prefer it, the reason we like to read that lead in first is because it provides a map. Especially when you get to step 2, the amount of information that you see, like in this vignette, there's a lot here. There's a lot you're going to have to sift and sort through. And if you don't know exactly what it is you're looking for to begin with, then you're going to find yourself getting through the vignette, then reading the question, and then needing to go back into the vignette to find supporting evidence, right? So the idea here, read that lead in, see that, okay, well, this they're looking at potentially initiating statin therapy. So maybe that helps me understand a little bit about this patient, as well as kind of where he is in his stay, right? So once you've read that, and you've kind of got your map, now we can go read the vignette. A 45-year-old man comes to his primary care physician after being told that he had elevated blood sugar at a community health screening event. He has a history of hypertension, and he is currently on hydrochlorothiazide. He has a family history of several family members with coronary heart disease in their 5th to 6th decade of life. He has smoked 20 cigarettes daily for the past 25 years, and he drinks alcohol socially. He is 170 centimeters, 5'7", and weighs 72 kilograms, 159 pounds. BMI is 24.9. Pulse is 64. Respirations are 16, and blood pressure is 135/75. Pulse oximetry on room air shows an oxygen saturation of 97%, and results of laboratory studies are shown below. Okay, so once you've read that vignette, taken all that in, we read the lead in one more time. which of the following most justifies the initiation of statin therapy for this patient? And you might already be thinking about, well, what answer might be there, or you can begin to hypothesize as I pass it over to Abraham.
All right. Thank you, Jeff. So Jeff did mention some really important points here. So step 2 is they love big fat vignettes. So unlike step 1, it's going to be a little bit more detailed. This can be seen as a good thing in the sense that they give you more information, but also can be tricky sometimes because they give you a lot of useless stuff or stuff that might not be as relevant. So it's your job as the physician to sift through this and be able to pick out what's the most important thing and what's clinically relevant in the situation. And that's why this method of reading the vignette for the lead-in first is very important. So let's go through, let's highlight some keywords here, and let's kind of break down what this paragraph is really trying to tell us. So we have the lead-in here. Most justifies the initiation of statin therapy for this patient. Okay, so you want to think about, it's not just your typical, what's the diagnosis, right? That's your step 1 typical questions that they ask. This is more kind of thinking on a clinical situation, right? You're going to see questions that are more prognosis related, more indications related, more guidelines you have to understand. That's where step 2 comes in. And that's why I found this question to be very important. I highlighted some stuff here. I'm going to talk about it and kind of walk through it as well. Okay. So 45-year-old man, so age and demographic is important, especially in these kind of questions where you're kind of in step 2, giving you a clinical situation. You want to know what's happening. Elevated blood pressure, so they don't give you a number, but he has a history of hypertension. He's on hydrochloric thiazide and family history of coronary artery disease. Okay. Smokes, so 20 pack a day for the past 25 years. Fine. 20 cigarettes daily for the past 24 years. And then they give you vitals. Okay, he's a little hypertensive. Outside of that, nothing standing out too much there. Labs here. Okay, so, it's important to look at labs and be able to kind of break it down, So these labs here, the total cholesterol is 170, which technically is within normal ranges. So normal is below 200. HDL is also, it's a little bit on the low end, 40 to 60 is normal. And LDL, it should be ideally below 160. That's 105. And that's why I just highlighted the HDL part. So it just shows us the low. Hemoglobin A1C is 8. So that generally is a little bit on the higher end, right? So these are values that you will have in your lab values, but interpreting them is up to you, right? Just because, different values show different things, you have to look at the full picture and not just, oh, this is normal, this is not normal. So that's something that's a skill that comes with step 2. And I'm going to talk about that today. So interpret these cholesterol and blood hemoglobin A1C results, look at the history, and really think about what would justify that the patient needs a statin, right? What do we know how statins work? Right? Step 1 would be like, hey, what's the mechanism of statin? Step 2 is, hey, what is the indication of statin therapy in this patient? And in his history, what tells you, hey, he needs to be on a statin? Okay, so let's take a second, understand that's what the question is trying to get at, and let's look at the options and break it down. All right, so we have 5 options here. I like to start with E and go to A, but everyone each their own. Option E, smoking history. Option choice B, hypertension. Option choice C, HDL cholesterol concentration. Option choice B, family history. Option choice A, diabetes mellitus. Which of these most justifies to initiate statin therapy in this patient? Very different style of vignette than your step 1, but this definitely is a very classic question that is very important to understand in cardiology, especially step 2 cardiology, where it's all about guidelines, all about when to know when statins are indicated and when it's not indicated. Take your time, read through it one more time if you need to, as we put the options up.
Okay, well, we're going to go ahead and we're going to launch the poll. And now you have the opportunity to tell us which of the following most justifies the initiation of statin therapy for this 45-year-old man. Make sure you could see all of the answer choices here. We've said it before, we'll say it again. You should never leave a question unanswered on test day. You're not going to be penalized for it. Don't want to leave anything blank. And we definitely don't want you to leave a question unanswered. Okay, let's see. Where are we at here? About 2/3 of you voted. So interesting kind of seeing the results here. Okay. I'll tell you what, about 3/4 of you have voted now. So I'm going to go ahead and I'm going to end the poll and share the results. Let's take a look at what we've got here. Okay. So hopefully you can see the poll. Answer choice A, diabetes mellitus, got the most votes, 26%. HDL cholesterol concentration also garnered quite a few votes, followed by family history, hypertension, and smoking history. So fairly mixed. I mean, across the board here. That sometimes here in Question Lab we'll have answer choices that get the lion's share of all the votes, but looks like there were there's some information here that's a little harder to parse. So let's go ahead and close the poll and let's reveal the answer. And the answer is answer choice A, diabetes mellitus. Good job that this was the leading vote getter, but again, tough question. These step 2 questions are definitely they're definitely going to be challenging. So if you didn't get it, or if you got it but you're not quite sure, you weren't 100% confident, that's okay, because this is where the learning starts. As I pass it over to Abraham.
All right. Well, great job, guys. And again, if you guys did not get this one right, do not worry about it. Especially a lot of you guys studying for step 1. Step 2, it's a different style of questions, a different way of thinking. And, it's really about learning from this concept. And this is something that you want to learn from and kind of will stick with you long term. So that's why I want to really pick this question. This is something that's very important to understand. Okay. So let's go back. Let's start from square one. This guy has been known to have this elevated blood sugar. Okay, we know that elevated blood sugar, they don't give you numbers or anything like that. But when you look at the labs, his A1C is 8%. Okay, so that's clearly diabetic, right? So he meets the criteria for diabetes because A1C over 6.5%, so 8% is diabetes. And, he has family history, hypertension, all that stuff. And that low HDL is kind of like a trap. So, that's a good second option. Low HDL is not a good thing. Low HDL can also increase risk for metabolic syndrome. But by itself, low HDL is not an indication to start a statin. You typically need low HDL, and then there's something called ASCVD, right? It's atherosclerotic cardiovascular disease risk score. So they'll give you that number typically. And if that's greater than 7.5, then you have to start a statin. So they didn't mention anything about the ASCVD score, and they just gave you a slightly low HDL. So that by itself is not an indication to start a statin. Let's look at the other options here. So smoking history, we know that smoking actually does increase risk for cardiac disease, and is an important risk factor, but it by itself is not an indication to start statin. It's more, again, then it goes back to ASCVD risk score. So the ASCVD risk essentially is this number they put out. It's a percentage number. It's the chance of you having an atherosclerotic event, so stroke, heart attack, whatever it is, in the next 10 years. So if it's a 7.5% or greater, means that in the next 10 years, your chance of getting one of those is greater than 7.5%. That is enough for you to be started on a statin. That's true, and that takes into account your smoking, that takes into account your HDL, LDL, all these other things, including hypertension and all these other options here. But diabetes mellitus is the only independent one, regardless of the ASCVD risk. If I have diabetes, you have to have a much stricter LDL control, right? So LDL, remember I said, if I look at my lab values, 105. Well, technically that's normal, right? LDL, as long as it's less than 160, we call it normal. And it's not going to even light up when I look at my lipid labs. But in someone with diabetes, the goal for LDL is even lower, right? So anybody with LDL concentration from 70 to 189. So 70 is going to be the cutoff there. So anything over 70, they need to be started on a statin. So diabetes is the single highest risk factor for stroke or heart disease. So diabetes is the most important. And if I had diabetes with any slight elevation of LDL, even if it's normal range, if it's over 70, you should be on a statin. So that's a good learning point to take away from this. And all these other things can increase risk for heart attacks and strokes. But remember, you got to always see if someone's A1C is up, likely that you need to be started on a statin at the same time you control their sugar. Hope you guys learned from this one. This is a good one.
Okay, this was a good start. And again, a lot of things coming at you in these questions, and appreciate everybody really focusing and working to get to the right response. But again, great explanation. Thank you, Abraham. Let's move to question number 2. So again, we've covered up all of the answer choices. This one is not quite as extensive as question number 1. And we start with that lead in. Which drug should be avoided in this patient? Okay, so I've got a little pharmacology here to be thinking about, and kind of know what we'll be looking for as we tackle the vignette, which we're going to do right now. The 63-year-old man is brought into the emergency department by his wife after he complains of acute onset chest pain. Like an elephant is sitting on my chest. After the patient is stabilized, his electrocardiogram is noted to have normal sinus rhythm with ST segment elevations in leads 2, 3, and ABF. His vital signs show a blood pressure of 125/80 and a heart rate of 70. He is not at a hospital that can perform a percutaneous coronary intervention. So once again, which drug should be avoided in this patient? Maybe you already have one in mind, but if not, what I'm going to do is pass it over to Abraham.
All right, so a little bit of a flip on this one. So this is still cardiology. This is now where we are dealing with an acute setting. So hospital, ED, somebody coming in with acute chest pain, right? And this is a little shorter of a vignette, but they do give you some key information. So the short ones are usually some ones where you have to pay attention to every single line, make sure you're not missing anything that's important. So let's highlight here again. So the question isn't mechanism of action, isn't the diagnosis, it's what drug should be avoided in this patient. Okay, so make sure you understand that. So you understand. They expect you to get the diagnosis, expect you to know what you would typically do and what you don't want to do. So that's the multi-step, step 2 style question. That's very important to do. 63-year-old man, of course, that's, demographics important, acute chest pain, right? So that's the presentation. So elephant sitting on my chest. I should bring some bells for you guys. That's the typical presentation. You need an EKG, you got ST segment elevations in leads 2, 3, AVF. What does that mean? I'll leave that to you. Now, blood pressure is okay. Heart rate's okay, but he's not in a hospital that can do PCI, percutaneous coronary intervention. So he cannot. So, not what should you do, but it's what should you not do in this patient that's presenting like this. So, take your time, understand the concept, look at all the information they give you, and let's look through the options here. All right. Option choice E, nitroglycerin. Option choice D, metoprolol. Option choice C, clopidogrel. Option choice B, aspirin. Option choice A, alteplase. Technically, these are all decent answers, and these are all have some role in the cardiac situation, right? And something, if someone's coming in, you consider all these. But in this particular patient, which should be avoided? And think about why. If you guys can think about why, you can put it in the question box here. Help kind of reiterate some of these concepts. That's very high yield. Take your time. Review the question one more time. Let's pull up the option.
Okay, we're going to go ahead and launch it. Let us know which of those drugs should be avoided for the 63-year-old man with acute onset chest pain. We do have the question box. I see some folks commenting and adding questions. We really appreciate that. And we'll do our best to answer questions as they come up. But we've got a two-person operation here tonight, so forgive us if we can't get to everything. One note is that we will be posting the video for tonight's session on YouTube probably by Thursday. Trying to get up there within about 48 hours. So if you came in late, or if you watched it and you wanted to check it out again or share it with your friends, that's where you'll be able to find it. Okay, we've got about almost 80% of you voted, so I'm going to go ahead and end the poll and let's share the results. Okay, so kind of a two-horse race here. Metoprolol edging out nitroglycerin. Also, a number of you went with alteplase. Nobody wanted to take clopidogrel off the table, and only a few of you went with aspirin. So, okay, interesting mix. Again, no dominant front runner. So let's go ahead and close the poll and reveal the answer. And the answer is answer choice E, nitroglycerin. So it got edged out, but it was a close one. But as Abraham said, these are all all relevant drugs, right? So if you got that one right, great. If you didn't, that's okay. We're here to get you on the right path. So I'm going to hand it back over to Abraham.
All right. Well, I see some good answers in the question box here. So let's talk about this. Don't worry if you guys didn't get this right. Again, another tricky one. This is a little, I would say, addition to your step one knowledge, right? So you need to know what this elevation in 2,3 ABF means. Really, that's kind of where the step one would ask you. It's like, hey, what does this mean to you? So this guy's coming in, we all know chest pain, elephant fitted sitting on the chest, ST second elevation. This guy's having STEMI. Very clearly, STEMI, he needs to get treatment right away. Typically, you would ideally be in a percutaneous coronary intervention psych hospital, and you get them into the cath lab, and you do a left heart cath, then you do balloon, stent, whatever needs to be done from the cardiology side. But he's not. Okay, so that's when we have to kind of reach into our pocket and start using medical treatments. That's when things like TPA, alteplase, is a good option. Things like aspirin and clopidogrel, which is our antiplatelet drugs, those work well. So those can also be used. And a lot of you pick metoprolol to avoid, right? So I'm going to explain why, you still want to consider metoprolol in the situation. You're right. Maybe you don't want to give it right away. Maybe you want to wait a little bit. But metoprolol, giving metoprolol post-MI actually reduces mortality, right? So he has normal vital sign, normal sinus rhythm. So he doesn't have a heart block, right? He doesn't have AV blocking MI. If he's having significant bradycardia, yes, avoid metoprolol. But he's 70, right? It's fine. You don't want the heart to go up in rate, right? The heart is already ischemic. You don't want to put increased demand of the heart. So metoprolol can be considered. So 2,3 AVF, what part of the heart does that supply? Right. So when I look at my EKGs, you gotta get familiar with when we have seeing ST elevations in 2,3 AVF. What does that mean? ST elevations of V1, V2, V3, V4. What does that mean? Right. Your like different parts of the heart is affected by different parts of the EKG. So there's this great references out there. If you go in first aid, they kind of break it down very nicely about which area correlates with which part of the heart. So 2,3 AVF is the inferior wall of the heart, like many of you guys mentioned in the question. And when I damage the inferior part of the heart, well, the right ventricle gets affected as well. So they become what's called preload dependent. Means that they need blood flowing into the right of the heart in order for you to have good cardiac output. Because the right ventricle, or the inferior portion of the heart, is really affected when you have this infarct. So nitrates, as we know, is a venous vasodilator. Essentially reduces preload in the heart. In most situations, that is a good thing, right? If I have, ischemia in a different part of my heart, I don't want my heart to work any harder. So I'm going to give nitrates to reduce the blood return to the heart, reduce my preload, reduce my venous return. But in this situation, this is the one situation which is very important. If I give this person nitrates, I'm going to significantly reduce the preload, leading to severe hypotension or cardiogenic shock. So you want to hold nitroglycerin in an inferior wall MI, which involves 2,3 ABF. So recognizing that this is the inferior wall MI, step one. Step two is understanding, okay, I can give TPA, I can give aspirin, I can give clopidogrel, I can give metoprolol, but nitroglycerin should not be given in the inferior wall MI as it can cause severe hypotension. So great learning point here. Great job if you got it right. If you didn't, hope you learned something from this one.
With that, let's get back into the fun. We are entering the second half of tonight's session and got question 3. So let's open it up. And once again, we've got those answer choices covered up. And we'll start with the lead-in. Which of the following findings in this patient indicates the need for endovascular intervention? Okay, so again, you're saving yourself a lot of time by reading that lead-in first, because you can already start to put together a picture of this patient. So with that, kind of again, kind of see the lead-in as kind of a map, kind of a compass to have in your head as you're going through the vignette. So let's read the vignette now. A 65-year-old man comes to his physician with a report of severe calf pain for the past week. The patient describes severe calf pain when he walks about 1 block, and that it does not completely go away after he stops walking and is at rest. Until recently, 1 month ago, he was able to walk up a steep street without calf pain, although he admits to avoiding this type of effort for a long time because it used to cause him chest tiredness and even pain. His medical history is unremarkable. He has smoked 1 pack of cigarettes per day for the past 30 years. Physical examination is notable for a right femoral bruit, as well as dorsalis pedis and posterior tibial artery pulses absent of palpation bilaterally. His toes appear purple and have no hair. His ankle brachial indexes are 0.6 on the right and 0.5 on the left. So once again, which of the following findings in this patient indicates the need for endovascular intervention? Some of that obviously is right there in front of you. So with that, I'm going to pass it over to Abraham.
All right. So another indication question. So this is a little bit different. So this is asking about kind of the surgical side of things, right? So endovascular intervention. This is still cardiology. This is still kind of understanding the cardiovascular CVT surgery, that kind of sign. It is very high yield to understand. You want to know what the patient has. You want to understand the situation. And then again, make that decision, know the guidelines, know the cutoffs that are required in this situation. Okay, so let's go through this. So the keywords here is which of the following findings is the patient indicates in this patient indicates the need for endovascular intervention. Okay, so again, indication here. Let's go through it. So 65-year-old man, okay, demographic, severe calf pain for the past week. Now, it happens when he walks 1 block, and it doesn't completely go away when he stops walking and at rest. And because of this, he's stopping any effort. He doesn't want to walk. He has even chest tightness and even pain when he does try to walk. He's a smoker, so 1 pack a day, so 30 pack years. and there's a right femoral bruit. And when you look at the different vessels, pulses are absent bilaterally. Toes are purple, no hair present. And then the ABI, or ankle brachial index, is 0.6 on the right side, 0.5 on the left side. So a lot of information here, a lot of little clues that they're giving you. And you should be able to think of a diagnosis just based on this. So once I get the diagnosis, you have to think, okay, typical treatment for the diagnosis is this. But what would I need to see to do the endovascular intervention? That's kind of the extreme option, right? So that's the one that I'm going to need some kind of surgical / endovascular intervention happening. So high yield here. Let's go through the options. This is a little tricky. So if you don't know this, don't feel bad. Just try to learn from this concept here. So let's look at the options here. So we have E, loss of hair on toes. D, leg pain at rest. C, femoral bruit. B, chest pain. A, ankle brachial index of 0.9 or lower. So again, we have this guy. He's been having calf pain for the past week. Worse when he walks, but also present at rest. Avoiding any kind of effort. He's lost hair in his legs as well, and it's associated with chest pain and tiredness. He's a smoker. There's a bruit, and his toes are purple, and there is ABI of 0.6 on the right and 0.5 on the left. So all these are present in this patient, but which one is the indicator that he needs endovascular intervention? And what's the key thing that, hey, this is endovascular intervention needed? Though a tough question, but I think this is high yield. This is what separates you from getting that really high score on step 2. So take your time and let's see what you get.
Okay, so let's go ahead and we're going to launch the poll, and you can let us know which of these findings in the 65-year-old man indicates the need for endovascular intervention.
Yeah, remember, it's not asking about what's needed to diagnose the patient, or it's not needed to say, hey, this is what the patient has. It's asking about what's needed for endovascular intervention.
Okay, well, folks jumping in on this one pretty quickly. That's great. Let's see how we do here. I also want to say thank you to all the questions and comments in the chat. Well, seeing some familiar faces, familiar names. Great to see everyone gathering here within the Question Lab community here at the end of September. Okay, well, over 80% of you have voted, so I'm going to get ready to end the poll and share results. And looks like another question or another good spread. So almost a third of you went with leg pain at rest. About a quarter of you went with femoral bruit, and close to similar numbers for ABI, chest pain, and loss of hair on toes. So, okay, interesting mix. Let's go ahead and I'm going to close the poll, and we will reveal the answer. And the answer is answer choice D, leg pain at rest. So nice work, everybody. Let me say, these questions are not getting easier. So you guys did a nice job with that one. If you didn't get it right, that's okay. This is, again, Question Lab is all about learning. It's all about, picking up tips and understanding that will help you on test day. So with that, I'll pass the baton back over to Abraham.
All right, great job, guys. Again, this is a tricky one, so I'm glad you guys were able to get it. If not, don't worry about it. This is a trick. This is a tough question for sure. So the diagnosis here, right? So that's the first thing you want to know. Someone's having calf pain, worse with exercise, and then he has like associated chest pain, is a smoker, is having poor pulses. This is peripheral artery disease, right? PAD. PAD is the diagnosis. Right away, you get that from the situation, the classic severe calf pain on exertion. All right. So he has risk factors and he has all the things that are diagnostic for it, right? So the symptoms is kind of the main thing that you use to diagnose PAD. So calf pain on exertion. So we call it, sometimes called a claudication. And that's the classic presentation that they present with. And, sometimes they'll even use the word pseudo-claudication, which is talking about actually nothing to do with peripheral artery disease, and it's talking about spinal stenosis. So that's a different differentiator you always want to keep in the back of your mind as well. But this is typical claudication. This is severe calf pain with activity. And the diagnostic criteria here, when, people don't have a typical presentation, is A, ankle brachial index as a 0.9 or lower, right? So if I have that, I can call it peripheral artery disease. But that's not what this question is asking. That's the hint I try to give you guys when you guys were looking at it. The question isn't asking, what's going to tell you this is peripheral artery disease? Well, definitely the symptoms will tell you. The ankle brachial index will tell you, but that's not an indicator for endovascular intervention. Really, there's only a few indications for endovascular intervention. Number one, it's pain at rest, right? The pain is only with exertion. You can do a few things, right? If I can do, okay, I'll say, hey, put them on an antiplatelet, put them on lipid-lowering therapy, do exercise therapy, the supervised that's pushing themselves a little bit more and more. Obviously, take away things like smoking cessation, lifestyle changes, things like that are important. So you want to modify risk factors. You want to do statins or other lipid-lowering therapies. You want to do exercise therapy. That's going to be the treatment for standard PAD. But if they have pain at rest, if they have something like a non-healing ulcer, so it's an ulcer on the end of the toe that's not getting better, if they have claudication that's so disabling that they can't even get up and do anything with themselves, those are the indications for endovascular intervention. So 3 indications that I just listed right now. So pain at rest, non-healing ulcers, and disabling claudication. Those are all important to note down. Those are my indications for endovascular intervention or revascularization in these situations, right? Loss of hair and toes, that just kind of points towards, okay, this is definitely PAD. Femoral bruit, same thing as a physical exam that shows there's some kind of stenosis and something going on. ABI less than 0.9. Again, that's a confirmatory finding. And the chest pain shows that he probably has some CAD as well going on in the background. So this is not going to be an indicator that you need to do something about the intervention there. So rest is the main defining feature. And somebody did mention it's a critical limb ischemia, right? So this is something that you want to think about. You want to think about that this leg is in trouble because he's not even exerting himself and he's having pain. So that's an indication for sure. So good job, guys. High yield topic here. Definitely a tough one, but one that you would take away and learn from, hopefully.
Well, nice work, everybody. Again, these some of you regulars, you've probably noted the the step up here in terms of challenge. So, but you guys are doing really well tonight. So, great work. So, with that, we've reached our final question, and here in the cleanup spot, question number 4. Let's go ahead and open it up. So again, as always, we've covered up those answer choices, and we are going to read the lead-in. Which of the following is the most appropriate next step in pharmacotherapy? Okay, so we got another pharma question in here. So let's go ahead and read the vignette. A 39-year-old woman comes to the clinic for follow-up for elevated blood pressure. 3 months ago, her blood pressure was normal, but at her last clinic visit 4 weeks ago, her blood pressure was 166/98, consistent with measured readings at home. She denies any history of diabetes mellitus, heart disease, or kidney disease. She denies taking nonsteroidal anti-inflammatory agents or other over-the-counter meds. She was prescribed chlorthalidone at her last clinic visit. She has no history of tobacco or alcohol use disorder. Today, her blood pressure is 152/94. Auscultation of the abdomen discloses bilateral flank bruits. The rest of the physical examination shows no abnormalities. So again, which of the following is the most appropriate next step in pharmacotherapy? With that, I'm going to pass it over to Abraham.
All right. So question 4, we're finally here. So this is kind of the pinnacle, that I would say, quote unquote, tougher question, but some people may not think so, right? Everyone's different. People find different things difficult, different things hard. This is talking about blood pressure, right? So we're dealing with a blood pressure situation and how you handle this. So let's go through, let's highlight some keywords here. Let's talk about some pharmacology here. So next step in pharmacotherapy. So this is asking about what do you want to give to treat the patient, right? So you're going to notice step 2 is a lot more about the pharmacology, a lot more about diagnosis, indications, treatments, as opposed to what's the mechanism of action, what's the cause behind it, or what's the diagnosis, like your step 1 asks. So you want to think one more step ahead. Okay. So again, next step in pharmacotherapy in this patient. Okay, you got a 39-year-old woman with hypertension. Okay, elevated blood pressure. It was normal, but then now it's 166/98. So it's a pretty high number for a 39-year-old, especially. No diabetes, no heart disease, no CKD. She's been not taking NSAIDs or over-the-counter medications, so denies. But she was taking chlorthalidone. Okay. Does not drink, does not have tobacco use. And today blood pressure went only down to 152/94. So it's still hypertensive. You start auscultating, you see, oh, there's bilateral flank bruit. What does that mean? Who knows, right? And then the physical exam shows no other abnormalities. So it'll give you some key important features here. And you want to take from the full story here and kind of come up with a diagnosis. That's the step 1 part. Then what do you want to do about that diagnosis? How do you treat that patient? How am I going to help treat the patient's blood pressure in this situation? So take your time, think about it as we pop up the options here. All right. So you got a bunch of antihypertensive medications. Option choice E, spironolactone. Option choice D, labetalol. Option choice C, furosemide. Option choice B, enalapril. Option choice A, amlodipine. Now, the question is, the patient is 39-year-old with hypertension, already on chlorthalidone, not having significant improvement, and the whole clinical picture should make you think of something that the patient has, and then you want to think about, okay, how do I treat that underlying condition? Take your time. If you guys know the answer, you guys can drop it in a question box, but we're going to pull up the poll very shortly. So take your time, go over it one more time if you need to. All right.
Okay, we've gone ahead and launched it. Last question of the night. What's the most appropriate next step in pharmacotherapy for this 39-year-old woman? Had some great questions tonight. Great comments from everybody. Good session. I've had a lot of fun here with all the step 2 items. Let us know in the question box what topic you think we should cover in our next question lab. Not sure if we'll have a Halloween edition of Question Lab. Double check our dates. We have been doing it, Question Lab. This is actually our second Question Lab of the month. We have been on more of a monthly schedule, so we've looked at picking up the pace a little bit with Question Lab. So let us know if you think we should be doing this a little bit more often. Okay, let's see. Almost 80% of you have voted, so let's go ahead and I'm going to end the poll and share the results. Okay, so looks like we had pretty strong showing for enalapril. Amlodipine came in second place here, and then a little bit of a drop here before the bitalol and furosemide, spironolactone. So, okay, interesting. Well, let's go ahead and close the poll and reveal the answer. And the answer is answer choice A, amlodipine. So, good job for those of you who nailed that one. I will note that this is a very tough question, and Abraham's going to walk us through it here. But you know, our percentage here in Question Lab is higher than the regular percentage of of QMax users. So you guys are outperforming the norm. So with that, I am going to pass it off to Abraham to walk us through this one.
All right. So this was kind of a tricky one, and it's kind of a little bit of a trap. So, I expected a lot of you guys to pick enalapril, and this is something that we have to kind of lock down. This is an important concept to understand. They love to test it. It's something that they'll bring up again and again. Step 1, step 2, you want to understand it. Okay. So clinically, you look at this patient. She is 39 years old. So a young female coming in with hypertension, right? So typically we don't expect people in this age to be this hypertensive. Sure, you can be a little hypertensive. They have other risk factors. They're a tobacco user. They have anything else. Maybe, right? But she has nothing else going on, just hypertension by itself. And it's pretty high, 166 over 98. And then even after starting chlorthalidone, which is the first line therapy, she only drops to 152 over 94. So this makes us think, okay, what's going on? There has to be some secondary cause to this hypertension. And that's the clue they give you with these physical exam. Auscultation of the abdomen shows bilateral flank bruit. Right? When I see bilateral flank bruit, whenever there are bruits, I think there's some kind of stenosis going on. Right? Remember the previous question we talked about peripheral artery disease? There's bruits there. Same idea. This is renal artery stenosis. Now, but she's not a smoker. She's not an old man with high cholesterol or anything like that. Why would she have renal artery stenosis? Well, this is something unique, right? So fibromuscular dysplasia is the most common cause of renal artery stenosis, especially in young females. So a younger female with resistant hypertension, you always got to think, oh, this patient may have fibromuscular dysplasia leading to renal artery stenosis. Now, it says bilateral flank bruit, right? So bilateral fibromuscular dysplasia leading to bilateral renal artery stenosis, which leads to resistant hypertension. Okay? So, how do we treat this patient? Well, you have to think about it, right? So you have to be careful whenever we have renal artery stenosis. The idea is that if I have renal artery stenosis, my kidneys become super dependent on the amount of blood flowing into the kidney, right? The afferent arteriole is stenosed. So therefore, less blood is coming into the kidney. Okay? So why is this answer wrong? Why is B wrong? Let's go through. Let's rule out C, D, and E first. Okay? So first of all, we're going down a different route, right? Spironolactone, we know it's a diuretic. It's a potassium-sparing diuretic. Typically, going to be your third line management of hypertension. It's not going to be anything you reach for first. And especially someone with bilateral renal artery stenosis, you don't want to make them more dry. So that would cause worsening kidney injury. Same thing with furosemide, same idea. It's good for fluid overload states, heart failure, things like that, but generally not a good blood pressure medication, and it can cause AKI as well. Labetalol is good to urgently control blood pressure, and it's not a best second-line agent. So it's like, hey, if someone is coming in with hypertensive emergency or an emergency, then you can reach for it, and it's great for them. But in this situation, it's not great, especially in a renal artery stenosis patient. Okay, between enalapril and amlodipine. Okay, why do we prefer amlodipine to enalapril? Enalapril, we know, is an ACE inhibitor, right? It's commonly used for blood pressure. It's usually our go-to, for sometimes you get second line therapy for hypertension. But in this situation, with bilateral renal artery stenosis, you would not want to use it, as when used, especially concomitant use of thiazide, you're going to worsen the kidneys. You're going to reduce the amount of perfusion to the kidney, therefore leading to worsened AKI. So bilateral renal artery stenosis, our drug of choice is usually amlodipine, which is a calcium channel blocker, which is preferred as a vasodilator. So the idea, you're going to dilate that renal artery stenosis and increase perfusion to the kidney. Therefore, the kidney is not going to activate the RAS system. Therefore, the blood pressure is going to be under better control. Renal artery stenosis is a high yield topic to understand, but you want to go amlodipine first in bilateral renal artery stenosis. Unilateral, yes, there is an argument that, hey, you can say enalapril could be the answer in the situation. But the fact that it's bilateral flank through is the key in this question. That takes it, you pick amlodipine over enalapril, and then none of the diuretics are going to be correct in the situation, and labetalol is only convergence. So great job, guys. You want to understand the concept here, understand that you want to vasodilate this renal artery stenosis. Good job.
Yeah, fantastic work, guys. This was a really good session. Good, high yield, but also some challenging items that kind of hopefully stretched you out. What do we tackle? We tackled how statin therapy indications and diabetes mellitus and cardiovascular risk management, right? We covered inferior wall STEMI management and contraindications for nitroglycerin. We did critical limb ischemia and indications for revascularization and peripheral arterial disease, right? And then obviously with this last one, renal artery stenosis and appropriate antihypertensive therapy selection. So that's good work. That is, we covered a lot. So, and big thanks obviously to Dr. Titus for guiding us through this step 2 minefield. Remember, obviously at this level, this isn't just about knowing facts. It's really understanding the clinical decision-making process and being able to apply guidelines to real patient scenarios.